I'm presenting my professor and also friend. I'm speaking of Professor Dr. Paula Perlea. She's a full professor at the Department of Endodontics at Carol Davila Faculty of Dentistry, Dean Emeritus in the period of 2016-2020, President of various societies, Romanian Society of Stomatology, Romanian Association of Endodontology, Romanian Medical Association. She graduated in 1993 as a valedictorian at the Carol Davila University of Medicine in Bucharest, and received her PhD magna cum laude at the Rupert Carl University, and completed postgraduate studies in endodontics at Case Western Reserve University in Cleveland, Ohio. Her specialization in maxillofacial radiodiagnosis and specialization in endodontics and general dentistry in Bucharest, and obtained her habilitation at Carol Davila University also. She published 158 research articles as main or co-author, 2 books as co-author, 3 books as main author, and held over 150 presentations and conferences in national and international congresses, and also organized more than 25 congresses so far. Professor Perlea is on 4 editorial boards, positioned in national and international journals of dental medicine, being also the executive editor of the Romanian Journal of Stomatology. She's also the chair of the membership liaison and support committee for the FDA National Liaison Officer, board member of ERO, European Regional Organization of the FDI, member of the Council of the Balkan Stomatological Society, and also member of the General Assembly of European Society of Endodontology, and not the least, member of the Alumni International Association of Student Clinicians at the ADA. So everybody, let me give the floor to Professor Perlea. Hello.
Hello, thank you so much, Dr. Constantinescu. It is a real pleasure to be here with you and with all the friends which are together in this very, very interesting conference. I will try to share the screen. I hope technology will help us. So, I think it's. Can you see my screen?
Not yet.
Not yet. Let's try it again. Let me do it again. So
Sharing is not restricted.
No? Okay.
No. Yeah, it's going. Yeah,
okay.
yeah.
Let me put the presentation. So you can see the presentation now. I want to be sure if the technology is working.
It's good. It's all good.
Okay. Thank you so much. Good morning, everyone, again. And I'm Professor Paula Perlea, and it's my pleasure to be part of the virtual conference InnoBioDent 2022. I was invited actually to make first a brief presentation of my CV, but Dr. Constantinescu made it perfectly, so I cannot add anything. As he said, I'm the president of the Romanian Society of Stomatology. For the moment, I'm the professor in the Department of Endodontics at Carol Davila University, and also the president of the Romanian Association of Endodontists. I'm very happy that I received the PhD in Heidelberg in Germany, which is a very, very famous university, and the postgraduate studies in Case Western Reserve University in Cleveland helped me a lot in my career as an endodontist. I'm also very happy to share my knowledge, not just with my students, but also all over the world in the conference I had in national and international congresses. Nevertheless, I'm happy to be editorial board member of the Romanian Journal of Stomatology and Stoma Edu Journal, which is organizing the Today conference. So I'm happy to be together with friends, with old friends and with new friends. Technology today shapes dentistry, and not just dentistry, but also endodontics. The trend nowadays is minimal invasive dentistry, faster and more efficient treatment, and better healing. The aim of the endodontic treatment is a complete chemomechanical cleansing of the root canal system, an adequate root canal filling of the endodontic space, and a good restoration of the tooth. For a better outcome of the endodontic treatment, we need technology. First, the CBCT, when the X-ray is inconclusive. The use of the dental operative microscope during the whole treatment, from the opening of the pulp chamber to the root canal filling, performed with thermoplasticide, gutta percha, the continuous wave of condensation, or gutta core obturators, or lately with bioceramic sealers. And the shaping phase, performed with new modified nickel titanium rotary instruments and activated irrigation, for example, with ultrasound or sonic tips. And don't forget about the laser, the nanotechnology, the gentle wave, the dynamic navigation, the piezoelectric devices, and so on. So technology is very important. The first one is the CBCT. So the impact of the CBCT in endodontics is enormous. Clinical examination and diagnostic imaging are essential components of preoperative diagnosis and treatment planning in endodontics. Accurate diagnosis imaging allows the clinician to better visualize the area in question and supports the clinical diagnosis, the treatment plan, and the outcome assessment. Conventional two-dimensional radiographs continue to be the most popular method of imaging today. However, the diagnostic potential of periapical radiographs is limited. Information may be difficult to interpret, especially when the anatomy and background pattern is complex. In 2010, a member of the American Board of Endodontics considered that 42% of the patients with endodontic pathology should be scanned using the CBCT. So it's quite a number. When we are using CBCT in endodontics, the best is to use the limited field of view. Why? Because the limited field of view is the most ideal in the endodontic diagnosis and treatment planning, because it is capable of providing images with sufficient spatial resolution, but at a very low radiation dose. And when we are looking at a CBCT, we can look at the axial or transversal plan, the coronal plan, the sagittal plan, or any other customized plan, which is important for visualization of the diagnosis or of the anatomy of the certain tooth. What are the most frequent indications for using the CBCT in endodontics? First of all, the preoperative anatomy assessment. And we can view the number of the roots and root canals, the root shape, the root and canals curvature, which are very important, the cross-section, the root canal volume, the obscure or unidentified canals, the extra root canals, or bifurcated canals. So we have a lot of anatomy particularities which we can visualize with a CBCT. Then we can use the CBCT for the endodontic diagnosis and detection of cracked teeth and vertical root fractures, which are not so easy to identify on the X-ray. Also for the detection of the periapical lesions, of the inflammatory resorptive defects, of the traumatic dental injuries. Then we can do the non-surgical or surgical treatment planning, the microsurgery. We can observe the healing of the periapical lesion, the quality of the root canal filling, and last but not least, the outcome of the endodontic treatment. I was saying that the best thing to do is to use the small field of view when using the CBCT. Why? First of all, we have lower radiation. We have a very good focus on the area of interest, a high resolution, a reduced processing time, a lower price, and less area of liability. We are using CBCT in endodontics nowadays in various occasions, but we have to know also the limits of the CBCT. First of all, the artifacts determined by radio-opaque materials like the post, the gutta-percha, the crowns. The artifacts due to the movement during exposure. And there is another problem, the soft tissue are not visualized. When do we have to refer a patient for a CBCT examination? First, when the diagnosis was uncertain. So if we do not know what the diagnosis is, so we know, but we are not certain of it, the subject were referred to CBCT scanning for additional imagistic information. And as I said, first of all, we have to visualize the anatomy, the morphology of the endodontic system. The success of endodontic treatment depends on the identification of the root canal system so that all the canals can be treated. The American Association of Endodontists recommends CBCT for initial treatment of teeth with potential for extra canals and suspected complex morphology, such as mandibular anterior teeth and maxillary and mandibular premolars and molars and dental anomalies. CBCT showed higher means values of specificity and sensitivity when compared to intraoral radiographic assessment in the detection, for example, of the MB2 canal in the upper molars. And I will give you an example of complex anatomy. We had a patient which was referred for retreatment of the tooth 2-6, and you see the preoperative X-ray. Actually, we can see two underfilled canals, the MB1 and the distal buccal, and the palatal root canal, which is not filled, and we couldn't see no reason for the missed canals. So we referred the patient to the CBCT, and what we could see. On the axial plane, we can see the missing MB2 and the perforation of the palatal root. Also on the coronal plane, we can see the perforation and also on the sagittal plane. So we could identify on the CBCT the reasons for the, let's say, failure of the endodontic treatment. Another clinical case, a patient was referred to us for the 2-7, which had a tender vertical percussion. And if we saw the X-ray, we could conclude that it's actually a satisfactory root canal filling and a good coronal reconstruction. But we decided to refer the patient to a CBCT, and what we could visualize, a considerable periapical lesion. It's visible also on the sagittal and on the coronal section, which we couldn't see on the X-ray, with a CBCT pi of 4, so the lesion is between 4 and 8 millimeter, and also the missed MB2, which is visible on the axial section. So the CBCT helped us a lot for the diagnosis of the 2-7. Another indication for CBCT are the localization of the separated instruments. And we have an example here. On the X-ray, we can see a 4-6 with a separate instrument in the mesial root. Performing the CBCT, we could find out the true morphology of the endodontic system and the localization of the separate instrument in the mesiolingual canal, which confluence with the mesiobuccal canal. So we could clearly identify the localization of the separated instrument and we could remove it. The CBCT is also useful in the detection of the cracked teeth and the vertical root fracture. The recommendation 6 of the American Association of Endodontists suggests that CBCT imaging should be done if clinical examination and 2D intraoral radiography are inconclusive in the detection of VRF, of vertical root fracture. And I will give you one example, 1-4. On the X-ray, we can see a lateral radiolucency, and we can think normally about a vertical root fracture. On the CBCT, on the axial view, we can clearly see the vertical root fracture. So it's a tooth which we cannot treat, although it looks, let's say, on the X-ray quite good. We have to extract this tooth. Another indication of the CBCT are the perforations. I will show you another clinical case. We have a 2-7 with moderate pain. The X-ray is inconclusive. What we could see on the CBCT, we can clearly see on the coronal section the interradicular perforation and the interradicular radiolucency, which is very important because we can have a good treatment planning and normally a predictable outcome of the endodontic treatment. Another indication is the non-surgical and surgical treatment planning. The diagnostic information directly influences treatment planning and clinical decision. Accurate data leads to better treatment decision and potentially more predictable outcomes. So we have to know the proximity of various anatomical sites, for example, the proximity of the mandibular canal. In this particular case, on the X-ray, we can see surrounding the root of 3-6, a large periapical lesion. On the CBCT, we could see the real extent of the demineralization and the relationship of the root apex with the inferior dental canal. There is no communication with the inferior dental canal and the buccal osseous plate is very thin. The tooth could be successfully endodontically retreatment and the information given by the CBCT were crucial. The endodontic diagnosis and detection of inflammatory resorptive defects can be also done with the help of the CBCT. Because the detection of the root resorption is often a challenging problem due to the quiescent nature of onset and varying clinical presentation. CBCT imaging is important in the localization and differentiation of external and internal resorptive defects and the determination of appropriate treatment and prognosis. We had a patient with X-ray on the front for the front teeth. 1-1, we could see the internal resorption. It was a palati-granuloma, but we referred the patient for a CBCT to see if we have any perforation and to see the extent of the inflammatory resorptive defect. On the CBCT, we could see that we had no perforation, so we knew how to approach the tooth, and also we could visualize an accessory lateral canal. But on the CBCT, we could really visualize this inflammatory resorption and to give us, again, the real extent of the demineralization. We can also detect the periapical disease because the CBCT visualization can detect the true extent of the periapical lesion and the proximity to important vital structures. We can also visualize and appreciate the increase or tendency towards healing of the periapical lesion, so the success or the failure of endodontic treatment. We have another patient, another clinical case, 2.7. It's not relevant, but on the CBCT, we could see the real extent of the periapical lesion, especially on the distal buccal root on the coronal plane, which couldn't be visualized on the X-ray. Also, the CBCT is used in assessing the healing of the periapical lesion and the effectiveness of the endodontic treatment. And it's very interesting that there are studies which are showing that if you are considering the healing rate, visualizing the periapical radiograph, it might be in a study a 79% success. And if you are visualizing it with a CBCT, the success rate is only 35%. So it's more accurate using the CBCT. So in conclusion, in difficult cases, cone beam CT gives us information about the existence shape, root canal diameter in any section at any level with low radiation doses in a single rotation around the patient to capture the images. The CBCT gives us the opportunity to put a precise diagnosis of periapical lesions. It facilitates the correct assessment of the quality of the root canal fillings, and it helps diagnose root fractures, internal or external resorptions, perforations, cure of periapical lesions after endodontic treatments, and pre-surgical assessment of anatomical situations. Another, let's say, innovative or new technology which I want to present is the dental operative microscope, which is a necessity in modern endodontology. You can only treat what you can see is the motto with which specialist Singu Kim, a professor at the University of Pennsylvania, was pushing dentists to practice microscopic endodontics. The dental operative microscope has revolutionized endodontic treatment by improving the quality and accuracy of the treatments thanks to magnification and coaxial illumination. The dental operative microscope gives us the opportunity to see a three-dimensional image preserving visual acuity at different levels of the root canal. When do we use the dental operative microscope in endodontics? Actually, during the entire endodontic treatment. We can visualize the accidental openings of the pulp chamber. We have to perform the access cavity with the dental operative microscope. We can locate the canal orifices in less accessible root canals or even the canal orifices of the root canals, which we can see without the microscope, but this gives us better acuity. The detection of additional canals, like the MB2 canal in the upper molars, the fourth or the fifth canal in lower molars, the second canal in premolars, and so on. The DLM enhanced visualization during cleaning and shaping. And we should do also the root canal filling under direct control of the dental operative microscope. In addition, we can diagnose the cracks and the fractures with the dental operative microscope, the perforation and the false pathways. We can locate and remove the separate instruments from the root canal. We can do the orthograde retreatment, and we better visualize and we can have a better precision during endodontic surgery, so microsurgery like periapical curettage, apical resection, and so on. You can clearly see that the visualization of endodontic morphology through the dental operative microscope is far better than without. We can, for example, see here to 7, and we can visualize the second buccal canal very clearly with the help of the dental operative microscope. And in this image, you can clearly see the difference between the clinical and the microscopical aspect when visualizing a tooth, so when visualizing the endodontic system. So besides the CBCT and the dental operative microscope, we have nowadays in endodontics the image-guided endodontic access. So besides the traditional endodontic access cavity, the conservative endodontic access cavity and the ninja endodontic access cavity, we can use the image-guided endodontic access, which uses imaging modalities available to the clinician like 2D radiography, as well as the CBCT, to plan the access cavity more precisely. Rather than prescribing a one-size-fits-all access design, we individually address the unique characteristics of the tooth that dictate the location and size of the access cavity. The goal is not necessarily to make the smallest possible access, but to strategically preserve the dentin, which is very important. One implementation of the radiologic image guided or CBCT access design is the dual access or truss access, which is the appropriate or recommended design in mandibular molars when the canal convergence is minimal and the plateau between the root canal orifice is large. Preservation of dentin contributes to the lingual and buccal walls of the tooth in preserving them, and it's very important for the straightening of the tooth walls. We have also the dynamic guided access. Dynamic guidance was first introduced to aid the correct placement of the implants. I think my colleagues have to mute the microphone, otherwise, we can hear not just my microphones, but also your microphone. So the dynamic guidance was first introduced to aid correct placement of dental implants. Based on this approach, dynamic guided access, DGA, was first applied in endodontics by Dr. Giles Moppin. DGA uses volumetric information from the patient's CBCT to plan an access cavity. Extraoral cameras report the position of the patient's jaw and the clinician's burr in three-dimensional space. The dentist, looking at the software interface, receives immediate feedback on the position of the burr in relation to the position of the planned access cavity and the tooth. Physical guides made with 3D printer based on CBCT and intraoral scanner information also help the clinician during endodontic access or microsurgery. When we are making a comparison between the dynamical guided access and the 3D guide, we have to know that DGA offers significant advantage over 3D printed static guides that do not estimate interocclusal distance, can only be used with low-speed handpiece burrs, require time to prepare, and do not allow for minor but important treatment plan changes that may occur during the procedure and which can lead to the unnecessary removal of dentin. DGA allows real-time modification of the treatment plan if necessary, does not require the time required for 3D printing, does not require burrs with a long intermediate part, and allows the use of high-speed burrs. Besides this, let's say, three innovative modern technology, I would also mention the rotary instruments. Why to use rotary instrument and not manual instruments? It's very important because we have faster treatment, reduced working time, better outcome, and better canal shape. When we are talking about rotary instruments, we are talking also about the rotary and the reciprocating endodontic instruments. They are reliable even in curved canals. The cleaning and the shaping of the root canal system is very efficient. The enlargement and the debridement removal and cleaning effect is very good, especially in the apical area, which is very important, and it's very hard to enlarge with manual instruments. The three-dimensional uniform widening of the canals while preserving the geometry of the root canals is possible using modern modified rotary instrument. We are using the crown down, and this is very important when using rotary instrument, And though we do not push the debris apically, and the cross-section of the canal is, even after the preparation, almost round. So we are using rotary instruments nowadays because we have more precision because of the flexibility of the instruments. And we have a lot of benefits for the geometry of the canal. For example, the rotary master file has an increased or a progressive taper. And because of this, the shape of the root canal is beneficial, not just, for the cleaning and shaping, but also for the root canal filling. We have from the beginning an increased volume of the irrigant solution due to the crown down enlargement. We have a favorable taper for vertical condensation. The technique is simplified. We can delegate the task to the instrument. What means this? We have less instruments, we have toe control, we have auto reverse, we have better controlled apical shaping and working length control. We make fewer X-rays for rotary instruments with apex finder included. We have less iatrogenic errors like ledging or perforation. We can use rotary instruments in retreatments, in desobturations, and very important, we can use rotary instruments with improved engines, with rotation control and torque control, which are very efficient. There are some disadvantages of the rotary instruments, like, we have to purchase a special endomotor. And there is another small disadvantage because due to the nickel titanium alloy properties, they don't have plastic deformation, so we are not aware of the cyclic fatigue and torsional stress. So we have to follow the recommendation of the manufacturer, because sometimes the rotary instruments are just single use, sometimes we use it 4 or 5 times, or sometimes we can use them more often. The separated instruments are harder to remove. Usually they are separating beyond the curvature, and the separated file instruments are longer. So you need special grasping systems. So, and with this, I will finish the presentation. We have to follow some rules to use the rotary instrument. To make it brief, we have some rules. Do not stay too long, do not push too hard. When you're done, just go away. So we have to have a sufficiently extended access cavity. The coronal orifices of the root canals have to be visible at the same time. We do not have to work under the cusps. We have to have a constant speed. We do not have to insert or withdraw the rotary instrument without rotation. We have to have a correct measurement of the working length. The scouting of the root canals has to be done with manual files for gaining information about the orientation of the canal curvatures, about the calcification of the root canal diameter, the hardness of the dentin. We have to establish the glide path to facilitate the safe passage of the rotary instruments for a predictable path. And we will gain a straight access to the first curvature or apical third due to the crown down approach. Nowadays on the market, there are numerous rotary instruments like the ProTaper, the ProTaper Next, the ProTaper Ultimate, the 3 Autozetics, the Reciproc, the Wave 1, the Wave 1 Gold, the One Shape, the Twisted Files or Twisted Files Adapted, the High Flex, the True Anatomy, and so on. So all these rotary instruments are very good, but it's very important to know how to use them. So the premises of predictable endodontic treatment has to combine classic and innovation. We have to have a proprietary assessment of the endodontic system and the correct diagnosis, clinical and using X-ray and CBCT, a correct access cavity, traditional, conservative, ninja, truss or DGA, a magnification and good illumination, the dental operative microscope, a proper dynamic irrigation, proper shaping with rotary instruments, and a correct root canal filling. So thank you so much, and I hope we will do together proper endodontic treatment. Thank you so much.